Okay, good morning everyone. Welcome to Pediatric Guidelines. I'm Dr. Permature. As always, if you are anywhere near the Tanglewood building, please join us in person at the Mill Mountain Conference Room. And thank you for all those who are signed on virtually. Today's speaker is Dr. Nicholas Ryder. He's a board-certified clinical immunologist and clinical informatics. He has long-standing expertise in the clinical management of patients with complex immunological disease and in clinical data science approaches for optimizing patient care. Dr. Ryder serves as professor in the Department of Health System and Implementation Science at Virginia Tech. And in addition, he is the Associate Chief Medical Information Officer focused on research data operations and clinical immunologist at the Carilion Clinic. His overarching research goals focuses on leveraging diverse computational approaches to improving diagnostic rates, real-time care, and clinical outcomes for patients with primary immune deficiencies. He and his team meld clinical immunology domain expertise and the technical aspects of AI research, machine learning, and statistics to solve problems facing the patients seen in clinic. Please join me in welcoming Dr. Nicholas Ryder.
Thank you, Dr. Permature. Appreciate the kind introduction. Really, opportunity to meet you all. I think beyond even sharing research and kind of what we've done from an academic standpoint, I'm just really grateful for the opportunity to come before you and meet you all because I'm relatively new. I've only been here for about a year, and I've only been in clinical practice here at Carilion for less than a year. So first, hello, my name's Nick Ryder. Great to be here. Second, I practice here at Tanglewood with many of you, and I'm up on the second floor in the Allergy Immunology Clinic. Grateful to be part of the terrific Allergy Immunology group led by Dr. Rebecca Shapira. And I do focus on these patients that we call PI, or primary immune disorders, or inborn errors of immunity. So you'll see PI and IEI peppered throughout my talk. I'll talk about that set of conditions. And then, my passion is really caring for these patients, getting them optimal care. So about 7 to 8 years ago, I became very interested in clinical informatics, and then learning health system, or an LHS, and approaches for building learning health systems to optimize care for these patients. So let's see if this works. There we go. Some disclosures that don't really have bearing on the talk. So what are we going to talk about today? So we'll talk about artificial intelligence a bit, machine learning and a learning health system in healthcare today. Talk a little bit about the history of that. Gets a lot of buzz, but surprisingly, there's actually quite a bit of history. The why and the rationale for our work are to focus on patients with primary immune disorders, and then focus on the work we've done around a learning health system and building a learning health system for patients with PI. And then, really as part of the Department of Health Systems and Implementation Science, really focusing on not just building the tools, but hopefully implementing them and sustaining them so that they have durability and lasting value for these patients. So, ChatGPT came on the floor in November 2022, and it revolutionized everyone's thinking about AI. But AI has a long history in healthcare, and there are really 3 epochs. A really wonderful review article from 2024 and JAMA that really talked about these 3 epochs, going back to really the 1950s in classical AI and expert systems that were rules-based to help drive clinical decision support way before there was an electronic health record. And then fast forward to around 2011 or so, where deep learning machine learning models were used to ingest disparate healthcare data to make predictions and forecast patient trajectories and so forth. And then, as mentioned, as we all know, in the 2020s or thereabouts, ChatGPT and the generative pre-trained transformers, or GPT models, large language models, generative AI came on the scene. But we've had this long-standing history leading up to today, and one of the questions that has been around is, how can this technology really make a difference for patients and for clinicians? And so current state healthcare today, there's a lot of publications out there. There's a lot of research use cases that have been advanced, and I think many of us are excited about ingesting disparate, complex healthcare data to make predictions about patients, ultimately to improve outcomes and care. But there's a question: has it really made a difference? And so this is definitely a focus of our work. And certainly the large language models, as mentioned with ChatGPT, the hope is that with these models, because they can predict the next anything, word, event, sentence, and paragraph, that perhaps they can be used as smart chatbots to help a clinician anywhere in the world, certainly in the United States, but anywhere in the world, to optimize patient care facilitate patient safety, and facilitate optimal outcomes. So who's read this book by Daniel Kahneman or knows of Kahneman's work? A couple hands I see. Great. So Daniel Kahneman, as many of you probably have heard of, was a Nobel Prize winning economist. Got the Nobel Prize in 2002 for his work in kind of melding economics with how humans make decisions under uncertainty. And I love his book, Thinking Fast and Slow. It's very interesting. And basically the premise is that we all operate with two systems of thinking. Where I'm going with this is, what can we actually expect out of AI? And I think this is an instructive, kind of paradigm. And system one in Kahneman's model is that kind of knee-jerk reaction, gut, feeling, immediate type, fast subconscious response to a question. And system two is much more, slow, conscious, effortful, but actually more reliable than system one. So we make a lot of errors, but we're fast with system one in general. We make less errors, but we're a little bit slower and it's a little more cognitively engaging. So system one might be, what's your home address? No problem, I can rip that off quickly. System two might be, here's a really complicated bill at a restaurant, calculate a 12% tip, or if you're really nice, a 25% tip, for your server. And so I would, propose that AI is actually very capable of doing system one level thinking. Like humans and other sentient beings, AI can ingest a lot of data, depending on how complex the model is, and certainly with LLMs, hundreds of billions of parameters ingesting that data, and then immediately give you back information quickly. Sometimes with errors, sometimes with hallucinations, and that's why we have to be mindful of the training, the data that goes into the model. But it's very good at system one level thinking. I would hypothesize and submit that not so good at doing system two reasoning, recall and memory being more system one, reasoning being more system two. And unlike humans and other sentient beings where we can reason, AI isn't so good at reasoning. It's not so good at providing the why. It's not so good at providing inference. So we want to use AI, and the way we think about AI for building a learning health system for patients with primary immune disorders is how can we build the systems and implement them in such a way that they're set up for success to improve patient outcomes and clinician outcomes? But where is AI really proving useful today? And there's a very nice review article out of the Journal of American Medical Informatics Association recently that really kind of showcased a number of these areas. And certainly reducing burden and cognitive burden for clinicians with large language models and helping to facilitate clinical documentation is a big area. Even patient engagement and interventions through the patient portal is another area. Personalizing patient care, extracting relevant information. Some of the use cases in extracting information from the EHR to make the EHR more useful has also been used, and then automating some of the redundant tasks that are quite onerous and bog us down as clinicians, like continually filling out prior authorizations. So where is all this going? Before I get into the immunology, the clinical immunology piece, I would say AI is exciting, but I'm more interested in how AI can fit into a system that can really optimize care. And so who's heard of a learning health system prior to today? If you read about a learning health system, see a couple hands going up? So just to level set, this is a really nice quote out of the Institute of Medicine Roundtable from 2011. So we've been thinking about this concept of, baking science, informatics or information science, incentives and culture, so the hard science and the soft science of healthcare into a system that essentially allows for improved care and outcomes, however you define that, whatever specialty you're in, with each churn of the system and each opportunity to interact with a patient. Not trivial, certainly. Takes a lot of change management, a lot of culture change, and some technology, and certainly people, most importantly, motivated to build something like this. But I would submit that AI is going to be useful if we move towards a learning health system as a country, really. And so this is a little bit academic highbrow, but there are some really nice published use cases in the literature that show the value of a learning health system. This is a very nice particular case study published out of Northwestern University in their medical center, where they baked in AI into a learning health system. What they did is they amalgamated the right people R&D and clinicians focused on specific clinical problems, and then the common data model or data that would serve towards addressing those clinical problems, whether that's optimizing breast cancer diagnosis and care, or optimizing the diagnosis of patients with rheumatologic conditions or immunologic conditions. And then they built in the back end a natural language processing, artificial intelligence pipeline to be able to extract information from the clinical notes. We know that 80% of the information in electronic health record actually resides in the clinical notes. And then that drives towards a multi-layered platform where you build in imaging data, you build in clinical notes and time series sensor data from the ICUs and the other units, structured EHR data like diagnostic codes, procedure codes, even omics if you have those. And then ultimately the goal is to make practice improvements nimbly by having this infrastructure and people who are able to access it and use it, driving educational initiatives, and then hopefully driving research and closing loops. So this is kind of where I think we've been, where we are, and where we're going with clinical AI, past, present, and future. In the past, we published a lot of papers, but I won't say that those papers necessarily made their way into patient care and made a difference for patients. I think today we're focused pretty heavily on not only developing AI models, but implementing them in such a way that it makes a difference for care. And then in the future, we haven't shown this yet, but that the economics of AI and standing up AI models, developing them, implementing them, sustaining them, actually drives value. And that is the costs are reduced and quality is improved. And that's something that I think we need to shoot for. So let me tell you now about our work with that kind of level setting around learning health systems and AI and clinical medicine. I call my group Chili. When I was at Texas Children's Hospital in Texas, we had chili peppers everywhere. So that made a lot more sense than Virginia, but I still like the acronym, which is the Computational Human Immunology Lab and Innovation Hub. And our group, which I'm grateful to be a part of and lead, involves medical students and graduate students. Hopefully we'll grow our team over time with additional funding. But we are really pervasively focused on a couple different arms and a couple different approaches. And the first approach is very much operationally oriented, and that is focusing on models, AI models that don't have to be exciting or complicated. They don't have to be paradigm shifting from a scientific standpoint, but they should be accurate, useful, transparent, and at the end of the day, improve clinical decision support and diagnosis for patients, and also make lives easier for clinicians. Very focused on that. The other arm, our other pathway that we focus on is really advancing science within the sphere of clinical immunology. And here we may use, advanced research computing at Virginia Tech and high performance compute environments like that, as well as working with large language models, working with neural networks, working with whatever model we need, with whatever data set we need to solve problems, understand the biology of these patients as well as their clinical journey. And so we're very interested in the domain of clinical immunology. And I would say, as a clinician and as clinicians, we have a tremendous role to play in advancing technology, health information systems, and AI in healthcare, because our clinical domain knowledge is incredibly valuable in making sure that AI makes a difference for healthcare and our patients. And so we do take a heavily biased approach in that the technology is important, the data science approaches are important, but knowing about the natural history of these patients, knowing about their phenotypes and their underlying genetic basis of disease, the biomarkers that are relevant, or maybe additional biomarkers that could be relevant that aren't known to be relevant today, is very important. And that kind of takes us from all of this noise of clinical data to a smaller data set that can be leveraged for not only building and training models, but then for whatever use case you'd want with that model, diagnosing patients, reducing risks, improving safety. And then we represent those concepts that are important with the clinical data that's readily available, hopefully. And every center is a bit different in the clinical data that they have available. And then the goal is, of course, to improve analytics. So a little bit of history in the space of artificial intelligence for primary immune disorders. Up until about 2023, I know we're in 2025 now, it's crazy. Where did January go? Thanks, it's over, and maybe we'll start to see more spring-like weather. This week, maybe not next. But as of about 2023, there were a number of published approaches really using structured electronic health record data single nucleotide variant data from the genomics world, and then also some flow cytometric data to make predictions about whether the patient had disease or not and what type of PI the patient might have. And this was done with, if you remember that first slide I showed, really epoch 2, 1 or 2 level AI. Rules-based classifiers, simple machine learning models, and really looking to predict risk of disease, whether the genomic variant was a gain of function, loss of function, and contributed to disease at all, or a laboratory phenotype. Then in early bit of last year, we published a paper on using text mining to be able to, and I'll show you some of that data, to predict risk of disease and whether an individual had PI or not. And so, what is primary immune disorder? It is considered generally individually rare disorders, so individually less than 200,000 individuals across the population in the US would have these individual disorders, but as a group, there are more than 200,000 individuals with these disorders, and they span now over 550 known genetic etiologies, 10 categories based by every arm of the immune system: defects of T cells, defects of B cells or antibody-producing cells, combined immune defects, complement defects, phagocyte defect. So we're learning more and more about these disorders, and what we once thought was that these patients only suffer recurrent and unusual infections. We do know that's still true, but we also know that these patients actually suffer immune dysregulation, recognizing self from non-self, multi-system patterns of autoimmune disease, as well as often hereditary predisposition to malignancy. So this is a very heterogeneous from clinical phenotype and genetic basis standpoint, which makes it challenging to build AI models to detect them and bring them to medical attention. So our first foray into AI machine learning in this space was really to compress something that I'll call the diagnostic lag. I'm going to explain that in the next slide. But why did we want to do this? Well, there's literature that abounds that individuals in this space, and certainly in many rare disease spaces, suffer a protracted journey from first symptom onset to ultimate diagnosis. And so no matter which type of PI, common variable immune deficiency and antibody deficiency, or immune dysregulatory disease, or other antibody deficiencies, these individuals from first symptom onset to diagnosis, really had a journey that spanned anywhere from 5 to 9 to 10 to 20 years, depending on the cohort that you look at. And that leads to everything we don't want in healthcare. That leads to long, painful journeys, lots of suffering, lots of clinician visits, suboptimal outcomes, often morbidity, of course, and mortality, as well as excessive costs. So if we think about the burden and how this really affects the patients, like what do they really feel about this? Let me just talk to you about the diagnostic odyssey and kind of this diagnostic lag. For any individual with any disease, they're born and many of them look healthy. Many of these children don't look like any other child. They look completely healthy. Their parents are very happy to welcome them into the world. And then at some point, they have their first prior immune disorder symptom. And then ultimately, at some point down the line, again, 5, 10, 15, 20 years later, they get a diagnosis, and then they have a multitude of outcomes that's dependent upon the time distance between the first PI symptom and the PI diagnosis. And so I would call this, and many of us call this in the field, the diagnostic lag. And so how does this affect the patient? Well, we just published a paper looking retrospective data, so I think this is the tip of the iceberg, very much scratching the surface. But if you look at patient-reported health, you ask a patient, how is your health? How do you feel about your health on a simple 5-point Likert score? What we know is that the distance between the first PI symptom and the diagnosis makes a difference, and that those that have longer diagnostic odysseys feel that their health is worse. We also know that the age of diagnosis is important. So if you've got a diagnostic lag that's longer and you get that diagnosis until you're older, that also contributes to impaired patient-reported health. The number of healthcare providers also plays into this. What we know is not important is who makes the diagnosis. So whether you're a general pediatrician, general internist, endocrinologist, dermatologist, or an immunologist, patients don't care. They just want to get to someone who can recognize these disorders and make the diagnosis and give them standard of care, optimal care. So again, if we can use health systems to operationalize AI to bring these patients to medical attention, we do expect that the hypothesis is they're going to do better, they're going to cost the health systems less, and importantly, their perceived health will be better. Has anyone heard of the Jeffrey Modell Foundation and the 10 warning signs of primary immune disorders? Okay, I see one hand. That is fantastic. So this is a heuristic, a rule of thumb that's been out for now over 30 years, put out by the Jeffrey Modell Foundation, which is a husband and wife, Fred and Vicki Modell, from New York City, that lost a son to primary immune disorder. They leveraged their tremendous intellectual and financial capital to start this foundation about 40 years ago, develop the 10 warning signs, this rule of thumb, so that any clinician out there in the world that's ever heard of these 10 warning signs, if they encountered a patient with one or two of them, in particular two of them, they might think, this patient could have PI, let's work them up for PI, let's send them to a clinical immunologist. And as you can see, these are non-sensitive, and we've studied these in detail. But things like 4 or more new ear infections with one within a year, or 2 or more serious sinus infections, or a family history of PI. And we looked at these warning signs and encoded them using computational methods, and so that they could be read quickly over millions of patients, and then dove into a real-world Optum data set where we verified about 41,000 real PI patients and asked the question, how many of these real verified PI patients actually have 1 or 2 or more of these warning signs? And so what you see on the left side of this diagram is essentially the relative weight or importance or enrichment of each of these warning signs in a PI population versus a very diverse medically and ethnically set of controls. So for example, warning sign 9 is almost 8-fold enriched amongst the PI cohort, and that is 2 or more deep-seated infections, including septicemia. Through this experience, we found that there was a massively statistically significant increase in the number of individuals with PI who had 2 or more warning signs compared amongst the PI population compared to the controls, and that the population of PI patients in the U.S. is about 60 per 100,000 individuals. So just to kind of give you a flavor for some of the medical diagnoses within these warning signs, in particular warning sign 9, since it was most enriched, immune dysregulation, inflammatory disease, autoimmune disease, as well as opportunistic infections were encoded within that. So we wanted to use highly informative features, again, using our background knowledge of clinical immunology to encode this in warning signs and then build models from that. So you say, okay, you told me PI might be collectively not rare, individually rare. So this is just speaking to that context of 60 per 100,000 individuals. Several months ago, the total population of the U.S. was about 331 million. If we do the math on that, the estimated U.S. PI population is roughly right about 200,000, which is at the level that you would say rare disease or not. Above 200,000 individuals in the U.S. is actually not considered a rare disease. And I would hypothesize that the individuals that we found had pretty robust clinical phenotypes. So we're probably seeing those individuals who are, very readily apparent as having PI. You think about the individuals who are just beginning to present, unusual presentations, or more subtle clinical phenotypes, probably double this number, or at least 50% higher. So just kind of getting in, and I'm going to be really respectful of time because as a clinician, I get very stressed out if patients are waiting for me. So I am going to make sure we're on time today. But let me share a little bit of our data. This is our first foray into using a computational approach for patient finding. We used, again, the Jeffrey Modell Foundation's Generation Epoch 1 AI, a rules-based classifier called the Spirit Analyzer. Spirit stands for the Software for Primary Immune Deficiency Recognition, Intervention, and Tracking, Spirit Analyzer. Talk a little bit more about how that works. But when I was at Texas Children's Hospital, we analyzed about half of the population of their health plan, almost all children and women who were being seen in the Women's Health Center there. This was about 185,000 individuals, and what we did simply was run the Spirit Analyzer over this population. Spirit Analyzer at a high level bins every member of a population into risk strata, risk for having immunological disease or PI. It's not a diagnostic tool, but it is a clinical decision support tool. When we ran Spirit over this 186,000-ish population, we found that really only about 1% had medium to high risk, and that's the N of 2188. It was about 1% of the population, medium to high risk of primary immune disorder. A year later, we looked at the number of diagnoses in that population that was medium to high risk that had either been given a PI diagnosis or what we're really calling a concerning diagnosis, another diagnosis that might tip you off that the individual could have a PI and should be referred. And what you can see as at the end of that year, there were 41 individuals who were given a PI diagnosis and 57 that had a concerning diagnosis. This is a non-interventional study, so this was just purely natural history, and we followed that medium to high-risk population. So what this told us was that out of the medium to high-risk population, 2,100, 2,200, about 100 were either given a diagnosis of PI or a diagnosis concerning for PI, about 5% of the population. So we felt encouraged when we looked at these diagnoses, and some of them were non-specific from that medium to high-risk population and from that group that was ultimately given a PI diagnosis, that Spirit Analyzer could take us from a massive population that's very diverse ethnically and medically from a complexity standpoint, down to a much smaller population that you could do analytics on. And your pretest probability of finding a patient with PI would be much higher. And so here are some of the PI diagnoses from that N of 41 cohort. These are some of the concerning diagnoses that we found. So cellulitis, not terribly concerning. Abscesses, yeah, a little more concerning. Recurrent otitis media, thinking about the 10 warning signs, so forth and so on. So not to say those 57 individuals have PI, but there are individuals that you might want to think, could this person have an underlying immune disorder? And then do your own risk stratification as to whether you test them, just follow them, or test and refer. So great, you did this initial pilot study. What next? Okay, we said that was just an encouragement to us. We think the Spirit Analyzer could be useful. Let's do a longitudinal study. So we moved on to an approach that I'm going to spend the next several minutes describing. We took the population, we implemented both Spirit Analyzer and a custom machine learning model to drill down on a population at risk and then identify who actually needs to be referred using our knowledge of clinical immunology and these tools to hopefully find that 60 per 100,000 individuals. And so here is our longitudinal study scheme at a high level. The first step, which I'll describe in detail, was using Spirit Analyzer to identify a high-risk population. And then we built a custom machine learning model that actually predicted in rank order the individuals who most needed to see a clinical immunologist early, as opposed to those who could potentially be followed over time. So let's spend just a couple minutes on each of those steps. Step one is the Spirit Analyzer, which I already mentioned, software for primary immune deficiency recognition and intervention and tracking. This is an Epoch 1 AI. It's a rules-based classifier, and the way it works is very computationally efficient in that it looks for pre-specified claims attributes, so pneumonia, meningitis, failure to thrive, recurrent infections, bronchiectasis, and then it applies a pre-specified fixed weight, not a learning algorithm, and ultimately counts those claims attributes of interest, multiplies the weight, and then calculates a risk score for each and every individual in the population. So very computationally efficient. You can run millions of patients through this thing in a matter of minutes and take your whole population and say, this is my 1% that's high risk, this is my 5% that's medium to low risk, and here are the other 95% or whatever, 94% who have no apparent claim of interest. Step two, so that's step one. Step two was our custom machine learning model. And this, we wanted to build a model that would say, okay, we've got 2,200 individuals. I can't refer all of those individuals into clinical immunology. If I went to Dr. Shapira, my section chief, and said, Rebecca, I need to get 2,200 patients in across our 5 clinicians, she would be like, there's the door. So, and she's very kind. So how do we get from 2,200 individuals to those individuals who most need to see a clinician? So we took a verified group of about 300 patients with PI and around 600 individuals who are very medically complex. Took data elements that we were already extracting for the Spirit Analyzer and built a machine learning model that could create a ratio of risk at the visit level compared to the total number of visits over a 12-month period for any given individual in the population, something called a PI ratio. So for example, if someone had been seen 10 times in a year and 5 of their visit risks were predicted to be a risk for PI, then they would have a PI ratio of 0.5, and then we can risk stratify, rank those individuals for referral. Just at a high level, showing you some of the model architectures we went through, some dense neural networks, logistic regression classifiers, support vector machine learning for us. Some overfit. Largely, we got good performance. We were able to tweak the models to be good performers. Ultimately, the green arrows show the performance of the 2 models we ended up using in step 2, a dense neural network with a single layer that had 128 nodes, and then a regularized logistic regression classifier. You can see that area under the curve, which is our primary metric, was very, very good, approaching 1, 98, 97%. This is our study protocol where we, for about 3 years, followed a cohort of individuals. So what you're seeing in September of 2019 was actually finding the patient and assembling the cohort. I'll show you a little bit of their demographics very soon. And then each yellow arrow, the horizontal arrow, represents 12 months of claims data that we ran through the Spirit Analyzer at 6-month intervals. So we took this population at 6-month intervals, extracted 12 months worth of claims data for them, ran that through the Spirit Analyzer, and then assessed who was high risk. We took those high risk individuals and then we ran them through our machine learning classifier to identify who should be prioritized for referral. This is our cohort. This time we over doubled it, about 430,000 individuals again from Texas Children's, very ethnically, socioeconomically representative of Houston and Harris County. We look at the bottom part of this table, you'll see that only about less than 1% of the individuals was high risk, deemed by Spirit, and the baseline of this cohort high risk was about 70 per 100,000 individuals. So what did we find from this first approach, looking at claims data analysis? So a little bit of a busy slide. I'm just showing you on the left the initial risk stratification categories for these 430,000 individuals. So you can see the high-risk group was only about 297 individuals. But what we saw when we looked back over 3 years is that the number of new primary immune disorder diagnoses and the hospitalization rate per capita were statistically enriched among those individuals who were in the high-risk category compared to the other two. Urgent care visits per year didn't quite meet statistical significance, but also was fairly distinct. So how about our outcomes for our second step, machine learning model? Again, a little bit of a busy slide. What I'm showing you here is the high-risk population in March of 2021 and then at 6-month intervals thereafter. And ultimately what we found is that we had 37 candidates that should be referred to a clinical immunologist, and this was based on clinical immunologist review of clinical notes, de-identified clinical notes, as a ground source of truth, to say, did the model get it right or wrong? And so those individuals who had this PI ratio which ranked highly were statistically enriched for referral compared to those who had a lower PI ratio. So just showing you some of the data in the upper left-hand corner, what the output of the model is. Again, these PI ratios in ranked order. And then in the lower left corner, the number of calls for high-risk visits, which would be the bar closer to the right, compared to low-risk visits, the bar on the left. So about 1/3 of the visits for this entire high-risk cohort were predicted to be of high risk. And then if we look at this PI risk ratio across our population, and we look at patients with known PI, you can see that this spanned anywhere from about 0.1 to about 0.4, depending on whether you had chronic granulomatous disease and you were hospitalized, or ataxic telangiectasia, or X-linked agammaglobulinemia. But then if we look at those individuals that didn't have a diagnosis and where they shook out, these are some of the individuals that the model picked out and suggested that these individuals should be referred. So then let me just in the next few minutes, just talk a little bit about that natural language processing approach that we've taken. So first approach, we talked about the 2-step Spirit Analyzer and custom machine learning model. That's all with claims data, all taking diagnostic codes, procedure codes out of the electronic health record or a claims repository and running analytics on it at the population level. This is taking the free text and building AI models to be able to discern from clinical notes whether the patient is likely to have an immune disorder versus a control. And so our scheme here was to parse a very diverse, again, from Texas Children's Hospital set of clinical notes and then build models on them. And so what we had was about 6,400 PI patients that had in excess of about 2 million notes. We indexed those notes on pre-diagnosis and post-diagnosis because we wanted to build our models on the notes before the patient was ever given a diagnosis. So we were training on the language that clinician used, knowing that ultimately these patients had PI, but before there was a sense that that was the case. And then we had about 28,000 controls and 2.3 million notes. We processed these and looked at the controls versus the pre-diagnosis PI, IEI patients, and what you can see is that any term enriched in the PI population enumerated about 122,000, but the domain-relevant terms were only about 300, and the domain-relevant terms were things like recurrent pneumonia, bronchiectasis, failure to thrive, etc. And this rolled up to 16 concepts that were relevant. And so how did the models perform? Let me just walk you through the slides. What I'm showing you is model T0 is basically giving the model, once it's trained to discriminate PI versus control, if you give the model everything up to time 0, to the time of diagnosis, the model was about 97% of the time could make the discrimination between a PI patient and control. How about if we give the model everything up to 6 months from diagnosis? Well, it did a good job and performance held steady. 12 months up to diagnosis, performance held steady. Even a year and a half out to diagnosis, still we're keeping an area under the precision recall curve, quite good, almost 0.94. And then even if we look at 36 months out from diagnosis, these classifiers are able to take that information, discriminate 95% of the time area under the curve, PI versus control. So, now our approach is to take the structured claims data, drill down on a population that's enriched, and then extract their electronic health record, clinical notes, run around NLP algorithms over that, and hopefully truncate the diagnostic odyssey by at least 3 years. I'm going to jump ahead by a few slides just because I know I want to give time for questions. And I want to just spend just a couple minutes because I want to drive home the relevance of what we're building, which I think hopefully I set the stage on. So you say, great, you built these things, you published papers, maybe you got grants, maybe you didn't, depending on the year. But ultimately, what's going to happen? Well, what we don't want to happen is this, and has anyone heard of the model graveyard? Is this a phrase that anyone's heard of? So the model graveyard is essentially where 90% of clinical models go to die. And that is, we build something cool, we give a talk, we write some papers, but the model never makes a difference for a patient. That is exactly what we don't want to happen. So how do we get around this? It is Super Bowl week. Go Eagles. So let me, using a American football analogy, think about implementation of AI models. We take a lot of time and effort, build our AI models, we're very proud of that, but building that AI model takes us from the one goal line to about the 20-yard line. To get us to the 50-yard line is the initial validation in a single population, like I've shown you thus far, a single population. The rest of the way to the other goal line and to scoring a touchdown, you don't want to hear me sing Fly Eagles Fly, but I hope I'm singing it a lot on Sunday, is the implementation and sustainment of the model. So tremendous amount of effort and work going into actually making it to a patient, making a difference for a patient, improving health system operations. And so while we're super jazzed up about AI, and we focus heavily on it, we're so proud of AI, if we neglect the health system, then these two will be very discordant. Now, thankfully, that health system looks nothing like Carilion Clinic, but we wouldn't want to be from an intentionality systems engineering standpoint, focusing so heavily on the AI that we don't focus on those other parts of the health system that are really important in the learning health system. The culture, the values, understanding how we do work, what are our workflows in clinical medicine as clinicians. And so that's where, as a clinical informaticist, I'm very excited about shaping health system, very excited about being part of the Department of Health System and Implementation Science, because I do think that clinical informatics can help reduce the number of models that goes into the model graveyard. And so we're trying to bridge that gap from what we build in the computational lab to actually that which is implemented not only locally but regionally and nationally through an ECHO. Has anyone heard of Project ECHO? Yay, great, so more people, more hands going up. So you know that this is a program out of the University of New Mexico whose tagline is really moving knowledge, not people, and it was piloted initially by a gastroenterologist named Sanjeev Arora, who was focusing on rural individuals with hepatitis C and advanced disease who could and deserved optimal care and could have much better outcomes, but because they lacked subspecialty care in their communities in many cases, didn't have access to that, which was a disparity for them, they came to University of Mexico with advanced disease. Now, Project ECHO has hundreds of disease-specific programs throughout the country. We launched PEPI, which is Project ECHO for primary immune disorders, about a year ago, and our focus is really as a multidisciplinary team. My colleagues at University of Virginia, Dr. Lawrence and Dr. Borsch, my colleague who's a nurse, Angie Tyree in Lynchburg, and then one of my grad students, Jacob Blakovich, really focused on both education and providing free subspecialty expert consultation to rural clinicians who may be experiencing patients who have PI or considerations about PI. And our focus here is, again, rural clinician case consultation. We're freely available to anyone in the world, but we're focused really on Appalachia. That's our focus, as well as analytics consultations. How do you stand up in a rural health system? Some of the models we built, because we also want to bridge that digital divide. We do a lot of lectures and webinars, so we've got education materials and a hopefully facilitate rapid QI. And so this is just a paradigm for echo in general, but specifically for PEPI, where you'd have rural care teams interacting through Zoom with us, whether that's through a webinar or a case consultation, and then some dialogue back and forth where all teach and all learn in this setting. We are looking to launch a CME initiative here at Carilion over the next year, so please be on the lookout for that. And ultimately, we hope to really facilitate both personalized and precision medicine. And the ultimate goal is the quintuple aim. We used to have a triple aim, a quadruple aim. Now there's a quintuple aim where we're focused on patient experience, population health, reducing costs, care team well-being, and health equity. And I think we can do that by focusing on patient-reported outcomes, clinical outcomes, cost effectiveness and comparative effectiveness research, as well as clinician feedback and social drivers of health. And so hopefully we'll get to that, not only are we doing research and implementing, but we're driving equitable value over time, and we'll drive more learning health system functionality. So just some key takeaways. I do believe AI can bring value to healthcare, but we need to set it up in such a way that it will be successful. And then I think that, health data systems, people are much more important than AI, and it's a piece of the puzzle. But that implementation and sustainment is critical, and really the sustainment piece never goes away. We never build a model and say, I'm so proud of my model, and then just walk away. It's continuing to tend to garden forever. And with that, many, many people to thank, especially you all for your attention. I'm happy to take any questions, and here's my email should you want to reach out, refer patients to me, pick my brain on something, talk about AI, geek out about healthcare data. I'm available. Thank you so much. Yes.
Okay. So of all the nerdy and excited things I could say, I want to talk about clinician acceptance of AI-generated data. So about 10 years ago in genetics, software programs started coming out that the software program would do facial recognition and then propose a list of genetic syndromes that the patient might have. And a lot of clinicians got very worried that they were going to be replaced by machines. So I want to understand better what is happening in the United States related to physician uptake of AI-generated data.
Yeah, just for our colleagues online, great question about kind of physician trust with AI and how are we moving the field towards acceptance by clinicians, because there have been a lot of negative vibes with AI implementation and the perception that maybe we'll be replaced. Yeah, it's a great question. I think there's a lot of work going into this space. There is, I think, a pervasive approach within the informatics community to focus more on augmentation, so augmented AI, because we understand that as that diagram that I showed with Kahneman, we aren't going to be replaced anytime soon, and I would submit that it's not going to happen, just because while the current state, even the best generative AI models are very good at suggesting and recommending things, they get things wrong, and they have to constantly be tended. So there is a strong push to build models for augmentation. There's a smaller push to develop models that are diagnostic and FDA cleared, and that's a very rigorous process. So whether you're talking about a skin lesion melanoma classifier or diabetic retinopathy classifier, that may shift. I think that will probably shift workforce numbers, but not replace clinicians. So I think that, the answer to your question is that the focus is really on augmented AI and producing models that help us as humans do our job better by unencumbering us rather than finding to replace us. And I think some of these negative experiences, like you mentioned with the facial recognition software, just drive that point home. A well-trained geneticist is going to know dysmorphology way better than an AI at this point. Like it may be good at telling us you're the right person to board flight whatever, United flight whatever, like you are who you say you are. But from a dysmorphology perspective, I think that humans are still outperforming models. Yes?
If I'm reading you correctly, the input for those models that you described are clinical observations, CPT codes. We all know that CPT codes may not represent the reality of the encounter, maybe even the totality of the clinical situation. And as a pulmonologist, I see kids all the time for recurrent pneumonias where I look back and I see they're at an urgent care and they say, we think you may have early pneumonia. That kind of data really makes that input not as accurate. So how does AI potentially help us with that?
Yeah, great question. The question is, there's a lot of noise in clinical data, especially claims data, CPT codes, diagnostic codes, and these are of course often used first and foremost to justify payments, not necessarily actually to represent the clinical condition of the individual. So if we're building models with these types of data, how trustworthy are the models? It's a fantastic question. We're very sensitive to this, and I think the answer is that the models are certainly not perfect. And to the prior question, an informed clinician is going to be much better at saying, this patient might have an immunologic disorder and I need to either refer them or work them up than a model is. But the sad reality is, at least in this space, is that most clinicians don't actually think of these patients. And I think the data bears that out. So, in this particular case, I think the models are very good and we have outcome data to show that they can at least get you to a population that's enriched for risk of these disorders. And then I think and that's why we go from claims data to EHR data, because the EHR data is also noisy, but the clinical text is very rich in information. And our hypothesis is, and we're going to find out, we're going to scale it, is that you can use the noisy claims data to get you to a population that then you can run more kind of fine-grained AI over. And that it's not a one-shot deal. It has to be done iteratively. And it's also not all AI-driven. This is, again, augmented. So my vision for this would be that you would see a population that would come to a set of humans that had domain expertise, like a care coordination team or population health team, where that set of humans would say, I'm not worried about these individuals. This didn't look like pneumonia. This was an overcall or whatever. Whereas, yeah, these 5 really need to see a clinical immunologist. So I think there again, your point is very well taken, and that's where we need to really have the full, kind of armamentarium of a learning health system. I think
I just really enjoyed the talk.
Thank you.
I'm coming at it from a little bit different point of view. I'm a surgeon, but we use this data all the time to try to help us improve efficiency, and we're in this big project trying to improve our OR efficiency. And that whole idea of having a model, and we've lived with a model that predicts our OR times, that's just been horrible. So we're trying to revise it. And so the things that I worry about, and very enthusiastic adopter of this kind of process. I'm an engineer and this all makes sense to me. But what I worry about is what we were just talking about, just the garbage in, garbage out.
Yeah.
So much noise. I love the idea of augmented AI. You have to have the reasoning that's helping the machine sort. But I also just worry about what gets embedded in our models, that, the disparities, the health equity issues, the things that we just we don't see it anymore. I just took care of a 13-year-old with a teratoma who began menses at 8 and was told by all of her physicians that having a lot of belly pain and being out of school when that happened, that's just okay, and that's normal, that's to be expected. Meanwhile, she's got a bowling ball in her pelvis that has been growing for the last 3-4 years. I worry about those kind of things that, yeah, and I don't know, I don't have, the question is, I guess, the iterative process, but I'm just worried about what becomes embedded in those models that we then just accept.
Yes.
Instead of question.
Yeah, the question again, and I think it's a terrific one, born out of, both an engineer and surgeon's perspective, that is super valuable, is the garbage in, garbage out phenomenon, and what's baked into the models, and how does that kind of inherent bias get propagated. Yeah, I mean, that worry should never go away, honestly. It's a perfect worry. In my view, it's a strong case for local validation, so that if a model is built somewhere and it's performed really well elsewhere, it still has to be revalidated in the center that it's being implemented. So, for example, when I was at Texas Children's, Epic would say to us, now the sepsis model is good to go. You guys can just flip it on. And we're like, no, because we flipped it on here and it doesn't perform well. And of course, that's been published in literature at places like University of Michigan. So I think, it's really important to validate it locally with local clinical domain expertise, because a surgeon who's looking at OR times is going to know a lot about why things are, going one way or the other than a model. So I think, it would have to be validated locally, and then it would build trust that way, as opposed to just flipping the switch, adopting it, and kind of assuming that it's going to be useful. And I think maybe one last question, then I can stick around.
So I think you answered a little bit with what you answered to Dr. Temez. So I'm in primary care, and my worry is that this would be another banner that would pop up, like consider, immunologic disorder and rheumatologic disorder, and we get all these banners, and then finally they haven't had spirometry in a year. And so, there's just alarm fatigue from us as well. And so my primary question is, where do you actually see this being integrated in the EHR to a place that doesn't cause alarm fatigue on the primary care or whatever level is going to be processing this data, and then is actually answered? Pragmatically, how does it operationalize?
Yeah, concern about alarm fatigue is legit, and as an informatician, I am very much against interruptive alerts. As a clinician, I'm even more against. So I would say it actually has to be pulled out of the battery experience between the patient and the clinician. I think it has to be pulled into really a population health level workflow where the clinician is engaged, like, hey, this is your patient. The algorithm flagged your patient as maybe having risk for this or that or the other thing. What do you think? So that there's a dialogue and an expectation set up that, there's going to be some analytics run, and you may hear about this, but I wouldn't want that to interrupt the clinician-patient dyad in the room, because I think, we're all pressured for time, and we want to give, our patients the that they deserve. And if we're getting 1,000 alerts from the EHR, it's just like cancel. I don't know, should we wrap up so folks can go to clinic? But then I can stick around. I know there's at least one other question. I'm happy to stick around. So thank you all so much.